This video is created for physiotherapy education and learning purposes only. The demonstrations and/or explanations are as per our experiences and are generalized and may not be appropriate for every patient or condition, which is more specific. This content should not be used as a substitute for textbooks but just as an aid to formulate answers better.
Hello, this is Dr. Ravina here, and today in this video we are going to discuss about posture, which is normal posture and its biomechanics, and altered posture. I've just listed down the important questions asked in the university papers. This topic is not just important from second BPT kinesiology point of view, but also important for third BPT and fourth BPT because individual abnormal postures may be asked in 3 markers and 7 markers respectively. Posture, by definition in Kistner, is presented as a position or attitude of the body, the relative arrangement of body parts for a specific activity, or a characteristic manner of bearing one's body. Basically, when we assess postures, we can assess two types of postures, which are static or dynamic postures. What are static postures? The body and its segments are aligned and maintained in certain position, like standing, sitting, lying, kneeling. So these are static postures. They are maintained in a particular position or aligned in a particular position for long periods of times, and that's when we assess the posture. And what are dynamic postures? They refer to postures in which the body or its segments are moving. Like for example, we have walking, running, jumping, throwing. All these aspects have the body moving constantly. So those are called as dynamic postures. So postural control, as we see, is a person's ability to maintain the stability of the body and its segment. This particular definition has been taken from Norkins. So if you see, postural control are of two types, which is proactive, as the term suggests, is anticipatory response, or reactive response, which means a compensatory response. Just to give a very simple example, proactive means that now suppose you have kept a 10 kg box in front of you and your aim is to lift that box and keep it on the table. So the anticipatory thought that I have to lift causes certain muscles to tense up even before the actual process of lifting. So those are called as proactive responses. Now what are reactive responses? They are compensatory in the sense that suppose you imagine that the box that you kept, you assume that it will be of 10 kgs, but when you're actually lifting you realize that it is 15 kgs, it is 5 kgs more, and you are not expecting it to be 15 kgs. So because it is more weight than you expected, there may be a chance that you would kind of lose balance in lifting it because you're not used to the thought that you have to lift a 15 kg box. So that might cause a compensatory stepping forward movement. So those are the reactive responses of lifting the weight. Now there are multiple factors which may affect your posture. Now we will discuss each and every aspect in the subsequent slides. One very important aspect which can alter posture is the absence or alteration of the inputs and the outputs. So now in case any segment of the body is injured, if the segment is injured, the afferent inputs coming from the segments towards the brain, the signaling will be altered. Because that signaling is altered, the output from the brain is also going to get altered. And as a result of which there may be a compromise of the stability in that part. Likewise, you must have seen in elderly, they do not function as quickly as compared to a younger person. The muscles are more atrophied, the neural system is more affected. So therefore, the counteraction to an opposing force may not have the same reaction time as much as that in a younger person. Again, that can alter a person's posture because of the destabilizing forces, because the output is not able to generate the same muscular reaction within that specific time frame as it is in a younger person. So just to give an example of an injury, if there is an ankle ligament injury, what happens is that there are those proprioceptors inside those ankle ligaments that can get affected, thereby affecting the kinesthetic sense of the foot. That means position as well as movement. This kinesthetic sense can get affected, thereby causing further loss of balance and stability, thereby affecting the posture. The next important factor that defines the posture is muscle synergy. But before we dive into details of muscle synergies, let us understand what are perturbation and its types. So perturbation refers to sudden changes in the condition that displaces the body's posture away from equilibrium. So there are two types of perturbations, which are sensory perturbations and mechanical perturbations. Sensory perturbations are what? If suppose a person is standing still and watching something and suddenly has eyes covered unexpectedly, which the person was not expecting, then there can be a sudden change in the body position or equilibrium. That is a sensory perturbation. Likewise, what is a mechanical perturbation? Mechanical perturbation means that if someone is standing still and suddenly there's someone who pushes them from behind, there is a change in the body center of mass. Eventually, the person might step forward or move forward, and there's a change in equilibrium and base of support. That is a mechanical perturbation. Let us now discuss fixed support strategies, which are ankle strategies and hip strategies in particular. Imagine you are standing on a carpet and someone in front of you pulls the carpet anteriorly. Your natural tendency is the backward motion of the body because someone has pulled it forward. That is because of your inertia. So if the ankle strategy is predominant, the muscles will start acting from distal to proximal to prevent the backward motion of the body, so that the muscles in the anterior aspects causing forward motion of the body will start acting, where the ankle will start with tibialis anterior action promoting dorsiflexion, which is towards the forward direction. Quadriceps will cause knee extension, again towards the forward direction. And abdominals will act in the lumbar spine to cause the forward lumbar flexion, followed by cervical flexion with the neck flexors. Likewise, if you're standing on the carpet and someone pulls the carpet from behind, the natural tendency of the body is to move forward because the person can fall forward because of inertia. So natural tendency for which muscles to act now? It will be the backward muscles to act, pulling the body in a backward direction. So now the plantar flexors, which is the gastrocnemius, will act, followed by knee flexors, which is the hamstrings, will act, and the paraspinal muscles of the lumbar spine and the neck extensors will act to extend the spine. Likewise, in similar situations, if hip is the moving strategy or hip is the predominant strategy that we are following, then the muscles will activate from proximal to distal response, which is very similar to what we saw here. So if it is a forward translation of the support surface, you might see an abdominal followed by quadriceps followed by tibialis anterior. If it's a backward translation of the support surface, that means it is pulled in the backward direction, whatever you are standing on. Then your paraspinals, which are neck extensors, will act with back extensors followed by hamstrings and your gastrocnemius muscles. So change in the support strategy. So if there is any change in the base of support or the entire body, you might have certain strategies that are used like stepping forward, stepping backward, sideways, or grasping in response to these changes, which are used both by the younger and older populations. But it is more possible to use by a younger. As you grow older, the reaction time reduces. That is why the person has a higher chance of falls. The previously discussed fixed strategies and change in support strategies are more of reactive strategies, in the sense they come after an occurrence of change in the equilibrium of the body. Whereas now head stabilizing strategies are more of proactive strategies which occur before there is any change that is subjected to the body. It's an anticipatory response. So these are basically done during the dynamic tasks such as walking, where the head is stabilized over the body, basically of two types, which are head stabilization in space, which is a modification of head position in anticipation that there may be some displacements in the body's center of gravity due to external forces or internally generated forces. And the other one is head stabilization on the trunk, meaning the head and trunk move in a single unit, like a single structure. There are certain external forces and internal forces that are known to alter posture. When we are discussing about external forces, the two primary things that affect posture are inertia and gravity. So whenever the person is standing in an erect standing posture, he cannot stand absolutely still. There is some amount of constant swaying motion that occurs in the body, which is called as the postural sway or the sway envelope. So the person doesn't remain stable straight. There may be some swaying to front, back, left, right, little towards the oblique direction that keeps on going on based on the effect of inertia and gravity. Also, there are something called as ground reaction forces. So whenever the body contacts the ground also has to push back. Every action has an equal and an opposite reaction. Now this pushing back also has a vector which is it represents, which are called as the ground reaction force vector, which has a vertical component as well as a horizontal component. Talking about the center of pressure, the point of application of the ground reaction force vector at the body is the body's center of pressure, which is located in the foot in unilateral stance and between the feet in bilateral standing posture. So that is your center of pressure. Likewise, we have certain internal forces which are acting to maintain the posture, which are the muscles, which are probably counteracting the external forces, as well as the passive tensile forces in ligaments, tendons, joint capsules, and other soft tissues, which also help in stabilizing the posture and counteracting the external unstabilizing forces. You also have something called as coincident action lines. Now, in ideal erect standing postures, the body segments are supposed to be aligned with each other. But if the ground reaction force vector and line of gravity are considered, they generally form a coincident line, which helps us in assessing the effects of the all the destabilizing forces at each joint. Now, in case there is a postural sway, the line of gravity kind of shifts a little, and because the line of gravity shifts, even the center of pressure will shift. Likewise, there are certain external and internal moments which are generated. Okay, these are the torques basically. Now, when the line of gravity passes through a joint axis, these torques are created around the joint, which needs to be counterbalanced by your internal muscle contraction. So, external gravitational torque counteracted by internal muscle contraction. Those are the external and internal moments which are generated at a joint axis. So whenever we are asked to talk about optimal posture, extremely ideal postures are not possible to achieve because there's some amount of sway. There are certain external movements generated by the gravitational forces external to the body, which need to be counterbalanced by the internal muscular contraction all the time. So that can happen. Now there is a way in which you measure the optimal posture. So you use something which is called as a plumb line. So it is basically a line which is having a weight on one end and it is dropped from the ceiling downwards. So you can assess posture in the frontal view, in the sagittal view, in all the possible positions like standing, sitting, etc. with the help of this plumb line. How to do that we will discuss in the subsequent slides. Whenever we are assessing the position of the major body segments in the lateral standing view, we need to see that the ankle is in neutral position, that is, it is midway between dorsiflexion and plantar flexion. The knee is placed more or less in complete extension. The hip is neutral and usually there are no anterior and posterior tilts. This is an ideal posture, but there is some amount of anterior tilt that is present in humans normally. The lumbosacral angle has 6 to 30 degrees of slight extension that you can see. The lumbar is lordotic, optimally kyphotic thoracic vertebrae and lordotic cervical vertebrae, and the head is in neutral, not in flexion or extension. This is the ideal position of the body segments in the lateral view. How do we identify which external movements are occurring and which muscles counterbalance those external movements by generating some internal movements? So if you look at the ankle joint, the line of gravity goes anterior to the ankle joint. Because there's an anterior movement of the line of gravity, there is a dorsiflexion movement that is created over there, and that needs to be counterbalanced by your gastrocnemius soleus, which are the plantar flexors. Likewise, at the knee joint, again it goes anterior to the knee joint, the line of gravity. So there is an anterior movement again generated at the knee joint that needs to be counterbalanced by your flexors, which are the hamstrings. At the hip joint, the line of gravity goes posteriorly, generating an extension movement that needs to be counteracted by your iliopsoas muscle, which are the hip flexors. Thereafter, in the sacroiliac joint, the line of gravity goes anteriorly, causing a nutation external movement that needs to be contracted by the transversus abdominis muscle. Likewise, in the lumbar spine, the line of gravity goes posteriorly, generating an extension or lordosis extension movement, which has to be contracted by the flexors, which are the rectus abdominis and the external and internal oblique muscles. In the thoracic spine, the line of gravity goes anteriorly, causing a flexion movement or a kyphotic movement, thereby that has to be counterbalanced by the extensors of the thoracic spine, like the longissimus thoracis, iliocostalis thoracis, spinalis thoracis, and semispinalis thoracis. In the cervical spine, the line of gravity goes posterior to the cervical spine. So it is a extensor or lordotic movement. Thereafter, that has to be counterbalanced by your anterior muscles or flexors like your scalenii anterior. Then you have the longus capitis and longus colli. Likewise, in the atlanto-occipital joint, generally the line of gravity goes anteriorly, causing a flexion moment, which needs to be counterbalanced by your rectus capitis posterior major and minor, semispinalis capitis and cervicis, splenius capitis and cervicis, and inferior and superior oblique muscles. All of these are the extensor muscles. In sagittal plane, there can be foot and toe deformities, most commonly being claw toes and hammer toes. They look very similar, but they are different. So if you see in claw toes, there is hyperextension of MTP, which is similar to that you have seen in the hammer toes, but there is flexion of both the PIP as well as the DIP in your claw toes, making it look like a claw. But in hammer toes, there is only flexion at the PIP, but DIP goes into hyperextension. So that is the difference, basic difference between claw toes and hammer toes. So if you see here in claw toes, the callus is formed on the dorsal aspect of the flexed phalanges which are there, because that is the area that is bearing the forces. There can be subluxations of the proximal phalanx that can occur, and because the toes go into clawing, the base of support reduces from here to here, thereby increasing the postural sway. Likewise, in hammer toes, you can see the callus formed on the superior aspect of the PIP, which we can see marked here because the shoes keep rubbing over it. There can be flexors which are stretched over the metatarsophalangeal joint because it is in hyperextension, while they can be shortened over the PIPs because it is in the flexed position. Likewise, the extensors are shortened over the MTP and stretched over the PIP. So in the sagittal plane, you can have two knee deformities. One is flexed knee postures, which commonly occur due to knee flexion contractures. So generally when the hamstrings are in contractures or your gastrosoleus are in contractures. So what happens in flexed knee posture is that your line of gravity, which is ideally supposed to pass anterior to the knee joint in normal scenario, here it passes posterior. Now because it is passing posterior, there is an increased work on quadriceps because now there is a flexor movement that is generated, which needs to be counterbalanced by your extensor muscle, which is quadriceps in this case. So obviously the knee does not bend on its own in weight bearing position. It comes along with ankle dorsiflexion as well as hip flexion. So therefore in ankle, it increases your plantar flexor activity. In the hip, because again it is in flexion, there is an increase in the hip extensor activity which needs to work to counterbalance those movements. Likewise, in the knee joint, you can also have the hyperextension, which is very commonly seen, also called as genu recurvatum. Here the LOG passes way ahead anteriorly as compared to the normal. So if normally it passes from here, here the LOG passes a little more forward than normal. So that is why there is a adaptive lengthening of the posterior capsule around the knee joint that is there. And there can be compression of the bony segments on the anterior aspect from the femur and the tibial ends. So it may be associated with equinus, where your gastro are overactive because there's a plantar flexion here, and then there is an associated hyperextension at the knee joint. So normally the pelvis should be neutral or in slight amount of anterior pelvic tilt. But sometimes if it comes with excessive anterior pelvic tilt, like in case of pregnant women and all, when the abdominal load is more, they develop a naturally increased anterior pelvic tilt. So anterior pelvic tilt comes with increased lumbar lordosis, increased thoracic kyphosis, and increased cervical lordosis. So all of this increased lordosis comes with posterior compression and facetal compression, thereby affecting the posterior intervertebral disc in the lumbar spine. Likewise, if there is an increased posterior pelvic tilt, there is a reduction in the lumbar lordosis, which also affects the spinal stability because it affects the spinal ability to withstand forces, because there's some amount of lumbar lordosis, thoracic kyphosis, and cervical lordosis that is necessary for the spine to be stable. If it becomes more like a flat back where the lordosis, kyphosis, and lordosis are reduced, then its ability to withstand forces also reduces. So in the vertebral column, as we discussed, the thoracic undergoes kyphosis, the lumbar and the cervical undergoes lordosis. But if the degree of kyphosis and lordosis to those particular segments are more than the optimal that is required, that can also be an pathology. So sometimes now in elderly women or postmenopausal women, there's something called as Dowager's hump that is developed, where there is the osteoporosis of the vertebrae and subsequently wedging, whereby there is a wedging or the collapse of the anterior aspect, and there is increase in the height of the posterior aspect of the vertebral body, causing a Dowager's hump in women. In men, there can be one segment which has wedging, where there's anterior wedging, which is shortening of the anterior height and increase in the posterior height of the vertebral body. Just one segment good enough to cause a steep increase in kyphosis at a particular segment, that is your gibbous, which happens in men. Now, in lordotic postures, usually, as I discussed, there is normally lordosis in lumbar and cervical, but if it is more than required, it can cause compression on the posterior aspects of the vertebrae and posterior annulus, whereas it can cause a distraction or traction forces or tensile forces on the anterior aspect of the vertebrae. Normally, the head should be positioned in neutral position. However, sometimes when the line of gravity goes more anteriorly as compared to normal, there can be a anteriorly placed head that is called as the forward head. Here, the extensor muscles of the cervical spine have to undergo constant contraction, thereby it can lead to further strain on the extensor muscles, and it also comes with the compression of the posterior structures of the vertebral column because of that constant cervical extensor activity that is there. So when we describe the optimal posture in anterior and posterior direction, let's discuss the anterior first. The head has to be in neutral, such that the line of gravity passes through the middle of forehead, nose, and chin, and the eyes and ears have to be equally at level and symmetrical to each other. Thereafter, the neck, you have to make sure that the right and left angles are equal and the clavicles are also symmetrical to each other. Coming to the chest, it passes through the line of gravity passes through the middle of the xiphoid process. The ribs have to be symmetrical on each side. Then when it comes to the abdominal, the line of gravity passes through the umbilicus or the navel, which is in the center. So the right and left waist angles have to be symmetrical. Now I have said right here and left here because we are looking at the person facing opposite. Okay, so then we come to the hip joint or the pelvis. The line has to pass through equidistant from the right and the left anterior superior iliac spines and pass through the pubic symphysis here. What you have to observe here is that the ASIs on both sides are at level. In the knees, it passes between the knees, equidistant from the medial joint lines or femoral condyles. So patella has to be facing anteriorly and in forward symmetrically at the same level, followed by at the ankles, the line of gravity passes in between the 2 feet, equidistant from the medial malleoli, and the malleoli should be symmetrical and at the same level to each other. Coming to the posterior aspect, when we are observing the head, line of gravity passes through the middle of the head. The head should be straight without tilting on any particular side. The arms have to be by the sides, hanging naturally with equal distance from the center of the body. The shoulders, as we see, the line of gravity has to pass along the vertebral column, bisecting it into two symmetrical halves. The scapula has to be at equidistant from the line of gravity, usually about 4 inches in adults from the center on either sides. At the hip level, it has to pass through the gluteal cleft of the buttocks, and the posterior superior iliac spine has to be at the same level. The gluteal folds have to be symmetrical. Coming to the knee joint, it has to be passing between the knee joints equidistance from the medial joint line, and you have to see that the knees are at the same level, the posterior creases are at the same level, followed by the last aspect, which is the ankle and feet that are there. It has to pass equidistant between the two medial malleoli, and the malleoli has to be at the same level. So you need to make sure that this particular table is given very well in Norkins, that if you're asked about the optimal posture in anterior and posterior view, you are stating the table in the exams. Pes planus refers to flat feet, which is a frontal plane deviation in the foot. Flat feet can be either rigid or flexible. So how do we know it is rigid or flexible is that when the person is asked to raise the heel with the toes in contact with the ground, if the arch is formed in the medial side, then it is a flexible flat feet. But if the arch doesn't even form with the toes in contact and the heel being raised, then it is called as a rigid flat feet. So basically it's the medial arch that is lower than usual, and the calcaneum may look everted more than 5 to 10 degrees. Whereas pes cavis means there is a high medial arch, higher than normal, usually more stable than pes planus, and the weight is borne more by the lateral ligaments and the lateral border of the foot, and the peroneus longus muscle is kind of overactive. So knee have two frontal deviations, which is genu valgum or knock knees, where the knees come in contact but the feet move away. Or there is genu varum, which is bow legs, where the knees move away while the foot come in contact with each other. So here in genu valgum, the mechanical axis is deviated more laterally, whereas here in varum, the mechanical axis gets deviated more medially. So in genu valgum, there is a medial joint opening, and that is there is tensile forces medially, and there is compression on the lateral aspect because of this posture, whereas in bowing there is medial joint compression and lateral opening or increased tensile forces laterally. A common deviation in frontal plane is called as scoliosis. Now, scoliosis can just be thoracic scoliosis, it can be lumbar scoliosis, or there can be a thoracolumbar scoliosis in one direction, which is a C type, or if there is a thoracolumbar scoliosis in opposite directions, that is an S-shaped scoliosis. So, all of these are types of scoliosis which occur in the frontal plane. So, sometimes they are functional, that means they can be reversed, and sometimes they're structural, that means even the bony structures or the skeletal structures and the soft tissues around also get involved, so which cannot be very easily corrected. So that is basically scoliosis. It comes with rotation of vertebrae, sometimes asymmetrical disc loading, and eventually there are different waist angles that are formed on either sides. There can be a sort of crowding of ribs on one side, there can be curves which are formed on one side, all of those things that are seen in scoliosis. Here we see three images of sitting. First one is erect sitting, second one is slumped sitting, third one is slouched sitting. If you see in the first two, the person is sitting without any backrest support of the chair. Third one, he's taking the backrest support while sitting. So if you see in the first one, the line of gravity is relatively close to the axis of rotation of head, neck and trunk. Here, the line of gravity is pretty much away from the axis of rotation of the head, neck and trunk. Here also it is away, but what is happening is that the back muscles do not have to work by themselves. They are compensated by the backrest of the chair. Just to summarize the three different types of postures, this is a sway back posture, this is the lordotic posture, and this is a flat back posture. So if you look at sway back posture, there is a good amount of shifting of the entire pelvic segment anteriorly, followed by slight posterior pelvic tilt causing the hip extension movement. Shifting of the thoracic segment posteriorly, as you can see here, and there is flexion of the upper thoracic part, thereby contributing to increased kyphosis and a forward head that comes with it. When it comes to the lordotic posture, there is an increase in the lumbosacral angle that we can see, followed by the increase in the thoracic kyphosis, followed by cervical lordosis. Coming to flat back, almost all the curves are sort of obliterated, whether it is lumbar lordosis or thoracic kyphosis or cervical lordosis, thereby causing a little bit of instability to the spine. And there may also be some amount of posterior pelvic tilt that may be seen here. These are the books of references which you need to follow for questions which are asked on posture. Just to summarize what needs to be written in an answer if asked in exams, first and foremost, read the question, understand the marking scheme. If definition is asked, it has to be word to word from the textbook. If they have asked a particular view, do not get mistaken between sagittal and frontal views. See that you're writing the answer to the view they have asked. This is a common mistake that I've seen as an examiner. Moreover, if possible, you can draw body diagrams just to explain whatever you are describing in the optimal posture. Try to make tables so that it's easier for you also. You don't miss out any points, as well as for the examiner. And if there are any deviations that are discussed, you can have a column where there is tight structures or compressed structures in one column, and then other column can have the stretched or under tensile forces, whatever you want to write. So try to make it in a neat format to get better marks and make it more clear in exams. If there are any further doubts or queries, feel free to comment in the comment box. Thank you for watching.